Hello, this will be the part 4 for diabetes mellitus. This is just for personal use, but if anyone finds it helpful, I'll be grateful for that. So, now let's continue to the long term complications of type 2 diabetes mellitus. So, the first one we'll study is diabetic retinopathy. So, if the HbA1c value is more than 7% in diabetes mellitus patients, there is a retinopathy and neuropathy. So, in retinopathy and neuropathy, the progression of the disease is similar. And in type 1 diabetes mellitus, it will take 5 years for the disease to progress, for the complication to progress. But in type 2 diabetes mellitus, it will take longer, that is 20 years. And as I have also written, disease of the eye and the kidney, so the retinopathy and the nephropathy, they progress or develop at the same rate. So that is why it takes almost the same time for both of them to mature in a diabetic patient. So what are the different markers for diabetic retinopathy? So the first marker is homocysteine levels. The second marker is albumin excretion rate, which uh, should be which is 30 to 300 milligrams per gram of urea, and serum creatinine levels, which is the better marker for specificity, and creatinine clearance, which is the better marker for sensitivity. So, what is the earliest manifestation of diabetic retinopathy? The earliest marker is microaneurysms. So, you can remember it like there's a mnemonic called mean. So, you'll see microaneurysms in inner nuclear layer. So, in the inner nuclear layer of the retina, you can see microaneurysms. There's also non-proliferative retinopathy, which can contribute to macular edema, which can lead to visual loss. And there is proliferative retinopathy. So, in proliferative retinopathy, there is neovascularization, vitreous hemorrhage, and retinal detachment. So, for treatment for proliferative retinopathy is pan-retinal photocoagulation using an anti-YAG laser and injection bevacizumab, which is an anti-vasoendothelial growth factor. Uh, the blindness due to proliferative retinopathy is 25 times more compared to non-proliferative retinopathy. And the primary cause of blindness with proliferative retinopathy is uh, like primary sorry not the cause, the like primary way to say like protective for blindness is, if you are a diabetic, keep the HbA1c levels below 7%, so have good control. If it is a proliferative retinopathy, then you the treatment can be like the HbA1c is not in control, so you can use pan-retinal photocoagulation with an Nd:YAG laser. You If that alone does not work, then we can also give injection bevacizumab, which is an anti-vasoendothelial growth factor. Now let's see what is the second complication, that is diabetic neuropathy. So it is the most common presentation. It can be seen in 50% of the diabetic patients. So there are sensory manifestations, motor manifestations, and autonomic manifestations. So in sensory manifestations, there is distal sensory loss. So there will be a vibration loss. So we can see the patient won't be able to sense a 128 hertz tuning fork, and it is due to unmyelinated C fibers. So it is also called small fiber neuropathy, like HIV, like which can be seen in HIV as well as diabetes mellitus. And there will be pain in the soles of the patient, and the treatment for this will be duloxetine duloxetine, pregabalin, gabapentin, or amitriptyline. So motor manifestation, it most commonly involves the third cranial nerve, and there is a involvement of third cranial nerve, but there is pupillary sparing, so the light reflex of the patient will be preserved. And in autonomic manifestations, there can be postural hypertension. So postural hypertension is when you record BP of a patient when he's supine and standing, there is a decrease in BP. So like suppose if you took BP while supine, the BP values while the patient stands up will decrease by 20 millimeters of mercury for the systolic blood pressure and by 10 millimeters of mercury for the diastolic blood pressure. For this, we can use midocrine for the autonomic manifestations. There can also be silent myocardial infarction, hypoglycemia, hypoglycemic unawareness, and there can be gastrointestinal disturbances like diarrhea and constipation. So for diarrhea, we'll give clonidine as treatment. Uh, then there is the complication of non-healing ulcers or neuropathic ulcers. So the ulcers will be at the sole, which will and on the sole it will be close to the heel or the metatarsal heads, and there is angiopathy, so there is delayed healing of the wound, and because of neuropathy the wounds, like it won't pain, so the wound is neglected. And third, there is increased level of sugar in the local tissue, so there is an increased bacterial, so there is bacterial growth in the ulcer, in the neglected ulcer. So third nerve, let's study about third nerve palsy with pupillary sparing. So it is seen in diabetes mellitus neuropathy, as we read. It can also be seen in berry aneurysms, which is aneurysm in the posterior communicating artery, and it can be due to atriovenous malformations. Now there are some extra points over here, like which is not related to the topic but still important. So the third nerve palsy is seen in Weber syndrome, Claude syndrome, Benedict syndrome, and Miller-Fisher syndrome. Miller-Fisher syndrome is related to GBS. Sixth nerve palsy. In sixth nerve palsy, you can see raised intracranial pressure. There is Millard-Globler syndrome and Wernicke's encephalopathy. And seventh nerve palsy, there is GBS or AIDP, sarcoidosis, Lyme's disease, and Milkerson-Rosenthal syndrome. So now let's study the last thing, that is infections in diabetes mellitus. So in diabetes patients, as we know, they are a bit immunocompromised, and as they have more sugar in their blood and in their cells, like more sugar in the blood, they are more susceptible to infections. So rhinocerebral mucormycosis is the first one we'll study. So in this, there will be a personality change in the patient. The patient will not have control of his bladder movements or bowel movements, so there will be urination or defecation in the clothes, and there will be a presence of black fungal mass in the nose. And the fungus encroaches the frontal lobe through the cribriform plate. And for rhinocerebral mucormycosis, the treatment will be intravenous amphotericin B. Diabetic dermopathy is the has three things. So delayed wound repair. There is acanthosis nigricans. So acanthosis nigricans, I think everyone knows, it is that uh, lining on the flexure area. So it can be seen in type 2 diabetes mellitus, PCOD patients, and patients with cancer of the pancreas and cancer of the colon. And there will be necrobasis lipidoica diabeticum. which is on wounds there will be some necrosis, and it will look like some fatty layer. Acute complications in diabetes mellitus. Let's see a scenario. If there's an unresponsive and unconscious type 2 diabetes mellitus patient with heart rate of 100 per minute and BP of 140 by 100, and we are not able to palpate the neck veins, and we do a glucometer and we check the capillary blood glucose, and it comes to 30 milligram percent. So it means the patient is already in hypoglycemia. So the treatment for this patient will be giving IV 25 to 50% dextrose. For the patient, if for the patient the glucometer shows 300 milligram percent in capillary blood glucose, uh, they can be a hyperosmolar coma or diabetic ketoacidosis. So differentiating on in them depends on looking at the ABG values as well as the RBS. So here is a chart. So if the patient has pH of 7.2, PCO2 is 40 millimeters, HCO3 is 15 millimeters, and there is no presence of ketones in the urine, and the RBS is 300, the patient is in type B lactic acidosis. But if the patient has urinary ketones present with the same values, it is diabetic ketoacidosis. But if the RBS of the patient is 600 milligram percent and the HCO3 is also increased and the pH is 7.38 and there's absence of urinary ketones, the patient is in hyperosmolar coma. And as we have read earlier, the treatment for diabetic ketoacidosis and hyperosmolar coma is regular insulin and NS, but given intravenously. So you should rule out metabolic causes, then rule out cerebral causes for unconscious patients, unconscious diabetic patients. Normal saline is used in crashing patients in diabetic ketoacidosis, hyperosmolar coma, and acute hypercalcemic saline. In diabetic ketoacidosis, only RL cannot be used at all. Ringer's lactate is used in burns, cholera, and metabolic acidosis. So this was just some extra stuff. But the main infection in diabetes mellitus we should know is rhinocerebral mucormycosis, and the treatment for it will be intravenous amphotericin B, which is an antifungal. So this ends the diabetes mellitus topic. This video is just for private use, but if anyone finds it helpful, I'll be grateful. And I do know I'm not perfect in explaining things, and sometimes I make mistakes, but I'm also a student, like I'm also learning currently, even though I have my license. So please spare me. Thank you.